Thank you very much. Yeah, apologies for anyone who's been in a session that I've chaired so far over the conference, but by a long way, this is the session I've been looking forward to the most. I'm kind of thinking, so the topic is, what do leaders want from analysts? It's an opportunity for you to get some unvarnished advice from a group of people who need the work that you produce, who use the products of the analysis that you provide. The panel's fantastic, and it's only 3/4 full, so you get an addition. I'll just introduce you briefly, and then I'm going to ask each one of the panel to just speak for about 5 minutes to the question, and then I'm going to open it out for questions from you guys. So I want to get as much interaction going as we possibly can. If I start closest to me, Kieran. So the biggest mistake we think we've made today in the conference organising is not putting Kieran's name on the agenda. So Kieran Patel.
Inviting me.
What's that? No, it was inviting Kieran. Yeah. Terrible error, but it's too late now. So Kieran Patel is a consultant cardiologist and is the Chief Medical Officer at UHCW in Coventry. Clara Day, who is a consultant nephrologist and the Chief Medical Officer at Birmingham Solihull Integrated Care Board. And then Amanda Sullivan, who's the Chief Exec at Nottingham and Nottinghamshire Integrated Care Board. So just an absolutely wonderful panel. We do have Sarah Jane Marsh, who is due to be joining us, but is currently, I think, in a meeting with a minister. So as excuses go, that's good, isn't it? So if I ask you to just do the 5 minutes, Clara, can I start with you? What do you want from analysts?
Yeah, no, certainly. So I'm a kidney doctor by trade, as Fraser said, and as a clinician, I'm used to using data as information all the time. It's data that I trust. It's presented in a way that's really helpful to me. It helps me diagnose. It helps me prognosticate. It helps me treat. It helps me measure outcomes, and it helps me iterate around management plans in that context. And now, as a chief medical officer, what I need to be able to do is to do the same, but for the population, as opposed to individual patients. And there's no doubt that we have data, but it's a bit all over the place and not often presented in a way that is helpful as information. So, fairly recently, in my previous role, I was looking about where we might put another dialysis unit. And so within the trust, we knew everybody we'd dialysed, we knew everybody who'd started dialysis in the last 10 years, and we knew the ones who were likely to start in the next 2 or 3 years. So we could then map out where we thought dialysis units would be, and we were able to put it kind of within a 1 mile radius of Smethwick, which is one of the highest take-on rates for dialysis in the country. So we were able to plot that through. But what it would have been great to be able to do is say, right, okay, those are the ones that we know about. What about the ones in general practice who have got chronic kidney disease, who may well end up with dialysis in 10 years' time, so that we can plan a little bit ahead of that. But then you think, okay, but actually I don't really want to just plan for dialysis. I'd like to know who the ones are in general practice so that I can treat them to delay their progression to kidney disease. And indeed, I'd like to know those who might develop kidney disease in general practice so that we can try and identify them first to predict who might need it. And I'd like to predict not just on their medical aspects, but to overlay the whole wider determinants of health, so educational levels, housing, etc. within that, so that you start to have a proper picture of your population. But I think it's fair to say that we're not at that stage yet. So it'd be lovely to be able to get to the point where I can have data for my population that, one, allows me to identify who to treat, stratify who to do that. Two, to be able to predict who I might need to treat in the future to prevent elements. And three, to be overlay far more than health data within that to be able to get a good picture of it. So that's what I'm kind of looking at from a kind of population health management issues. I, of course, deal with performance and other issues as well, but I'm sure others will have to say with that. The other thing is that data presentation. I can't remember the chap who just came beforehand, but I cannot stand those up and down arrows that are red or green on an arbitrary basis, and I almost want to bang my head against the table every time I see them. And so it's presenting data as information is what we need. And so, one, presenting it in a way that intellectually has some sense, but two, thinking about how we train people more around data literacy, because we may have the data, we may be able to translate that into information for a way that we're able to interpret it, but it's got to be able to go into a wider audience to be able to interpret that quite a lot. I always used to talk about pictures, not pivot tables for clinicians. So it's, again, how we use the data we've got to relevant information.
That's wonderful, thank you. So as well as what do leaders want from analysts, what do leaders not want as well? So the arrows, no arrows, don't do the arrows. Thank you. Amanda, would you offer your thoughts?
Yes, thank you. So I'm probably thinking about it from, certainly from a population point of view, like Clara, but also from a bit of a kind of management of lots of different issues and trying to see the wood for the trees, really. So there's probably four main things I need from you all. First of all is to be an advisor in decision making, in that you can inform decisions and give context about data as well. And because I think it can be deliberately or unknowingly used to support a particular viewpoint. So I think the objectivity and the, well, it could be this or it could be that analysts bring to the conversations I greatly value. And then linked to that, a second thing is to be an honest broker, a sort of neutral, honest broker in some of the more contentious and wicked problems, because again, and I think we are getting more and more able to look at data differently, look at it with different population overlays and things as well. But there are, areas where there are contentious issues. So an example recently for us is around hospital discharge, and whichever bit of the pathway you're in, whichever service you're in, you'll have a view about why discharges are delayed. And that may well be different from other people's views about why things get delayed or what the issues are. Is it capacity? Is it process? Is it culture, handoffs? It's probably all of those, actually. And we've recently spent quite a lot of time developing a single view of what is going on across health and care and different providers, different sectors. It's still being iterated, and it's taken quite a while to get it all to kind of talk to each other. So we've had some really excellent input, and so the analysts have helped us to do that, as well as to then interpret what we see. And that has changed the conversations in a way I would really hope that it would. And it's given some new insights and understandings that we wouldn't have had when everybody's looking at their own bits of data and their own numbers, because it doesn't all necessarily make sense to other people who you need to be working with. So it's that sort of honest broker and fresh insights as well, by aggregating things and looking at what that means for an overall pathway. And then I think thirdly, it's the skills that you bring and the way that you are able to look at information and data to produce intelligence and to ask some new questions and to think about things differently, or to try and get to the heart of what things that we haven't actually got to the heart of yet. So an example of this, again, locally, was looking at identifying which people or households were at most risk from fuel poverty. And that needed an overlay of some social care data, public health data, and GP data, because it was a combination of economic factors and long-term conditions that gave us a kind of a vulnerability index. And that helped our place-based partnerships and the integrated care teams in communities to target very specifically help, advice, interventions. So again, that was actually quite a game changer in terms of how we could target vulnerable households. And then a fourth one is bringing a very collegiate way of working and collaborating whether that's within a system, across different provider sectors, working with local government, public health teams. But again, I think that collaboration skills, both in terms of problem solving, but sharing information, working out how we can mesh information and data together to get new insights, I think is really important and will be increasingly important in the world, I think, in analysts' circles, because we rely on that in order to get a better understanding of the population and how best to prevent disease as well as to treat it. Thank you.
That's wonderful, thank you. I'm guessing much of what you just said is music to analyst ears. And also I like the way that some of what you were describing was some of what Clara was describing wanting. So the link with some of the data on wider determinants, for example, just kind of shows that it's practically possible too. Kieran, do you want to offer your perspectives?
Yeah, I mean, I think you guys have said it all, haven't you, really? Which is spot on. I'm just going to make 5 points very quickly, really. So the first thing is, I encourage our analysts and the P&I team to challenge me, to make sure that we have what is relevant. Because I think we have too much data. The NHS is awash with data, but do we have the right data? And are we asking the right questions? I always tell our analysts to say, right, push back when somebody asks for something and say, what is it that you want answering? So let's get the question right from the outset. Otherwise, you just end up with a question that leads to another question that leads to a lot of insoluble problems, which then lead to their own data sets, and you end up with 1,000 data sets a day, and you don't answer the question. So the first thing is make sure that we have relevant data, and only you guys can tell us what the relevant data is when I give you the right question, or we collectively come to asking the right question. And I think when you get to the right question, the secondary phenomenon is that we need a rich data set. And I say rich because it's very rare that X correlates with Y in terms of an intervention and an outcome. But actually there are many multivariate analyses that lie beneath outcomes in healthcare or the interventions that we see. Great example I'll give you is winter planning, and kind of Peter smirking. So how many millions of pounds do we throw at winter planning every year without doing any evaluation of any of those interventions before we do the same again the next year? Actually, it takes a bit of time to just sit down and say, right, the question we want to ask is, how do we make the front door quieter or more manageable? What's the intervention? What is the data that will tell us the efficacy of the intervention so that you evaluate it? And that's just the way of looking at it. So because healthcare and healthcare outcomes is necessarily complex, data sets need to be rich. And some of that data is quantitative, but some of it is qualitative, which can be equally assessed and published. So relevant and rich are the first two things. The third phenomenon is that the data has to be real time. So when I get a data set that tells me what my cardiac surgical outcomes were in 2018, it's absolutely meaningless. I'm not going to go back and resolve something that might have already been done. So we're in an era where we are real time as a society, aren't we? So I think it's futile to have data sets that actually are almost 12 months old sometimes. And I think as an NHS, we need to get better at that. If we can generate the data real time, we can have it real time in this era that we're in. So let's look at data real time so that the interventions actually start to make sense. And we can do that, and industry uses it day in, day out. The airlines model their capacity for tomorrow based upon the activity today. And we're an airline-based industry, aren't we? I guess the fourth area is that the data has to be comparable. So where we can benchmark or judge where we are against peers, that drives change and it drives curiosity. Whereas a single data set in isolation doesn't mean a lot. It's just an observational data set. And I'm a cardiologist. The most powerful driver for me to change my clinical practice or for me to drive any change amongst 44 specialties that I have is to say, you know what, you're here, but actually everybody else is over here. Yeah. So you've got to be able to benchmark and drive comparative analyses. And I put it to you that actually too often we look at an inward-facing comparative analysis in the NHS. Actually, let's look internationally. If we want to get some of the best health outcomes in the world to align to some of the narratives and the strategies that we pump out every day, then you've got to look internationally. to judge yourself against peers, but then try to explain why you may or may not be different. Sometimes it's because health systems are differentially designed and funded. Sometimes it's because clinical practice has variation when you look at diagnostics and pathways and workflows. But actually, it's only when you have the comparative nature of the data set that you can then start to drill into questions. And I'd like to say that actually the purpose of my P&I team and the analytical team is to drive curiosity, okay? Not just to drive the data set and give me a set of tables or red and green charts, as Clara puts it, but actually let's make everybody curious about what we're seeing every day, because unless you have that, we don't get behavioural change and we don't get any inspiration into the system. So I often use the phrase that actually the purpose of both the analytical team and the R&D department is to drive a culture of curiosity across the organisation, because that then drives the questions that we need to generate the data and the analytics for, that drive the change. And when you do that, actually, you drive innovation as well. And it can be real fun. So I think, I talk about, the work we did during COVID. And when we looked at data and demography, we saw that health inequalities were a real problem. We published one of the early smoke signals of inequality during COVID back in April 2020. And we saw elective care was going to be a problem. So we started planning with our analysts what a data set could look like that could drive elective restoration and reduce inequality at the same time, way before anybody started talking about it at the national level. And that's designed, and we now have a software package that actually does what it says on the tin. But that took 2 years to develop in terms of the data set and change. Which then brings me on to the fifth point, that I think everything we do should really be aimed at driving quality improvement. So if we're generating data that at the outset is purely observational, then I challenge back and say to you, should it not be driving some element of quality improvement somewhere along the line? And I think the analytical teams are fundamental to driving quality improvement, because you can generate the right data set, because you can show me the comparative analyses, and because you can make it as real time as possible. So I think QI is underpinned by good data, in my view. And we're coupled with the Virginia Mason Institute in Seattle, which is espoused to be one of the safest hospitals in the world. And one of the things they do is act very real time based upon data. So we've got a lot to learn from there. I'll stop there.
You can stop there, but that timing's amazing. Thank you, Kieran. See how good your improvisation is now. Then, so we've just been going around about 5 minutes each on what leaders would like from analysts. Are you happy to do your 5 minutes now, or would you like me to cut to some questions?
I'm very happy to do mine.
Are you?
Yeah,
okay.
Absolutely, yeah.
Wonderful.
Okay, so first thing to say is good afternoon, everybody. I'm sure you knew where the missing person on the chair was, but my name's Sarah Jane Marsh. I'm the National Director of Urgent and Emergency Care and Deputy Chief Operator at NHS England. It's a real privilege to be invited to be part of this. I was sweating it out in a ministerial meeting where, quite frankly, I could have done with a bit more analytics before I went in, but I managed anyway. So I've made a few notes, and I don't know if obviously I'm repeating what other people have said, but I think the first thing to say is I'm only half joking when I say what I've just said. Like, if you haven't got proper analytics, if you haven't got proper data and understanding and appreciation, it's very difficult to make a case for anything. You end up going in with a series of stories and anecdotes. So it's just an absolutely vital part, I think, of any of the leadership roles that we hold, that you've got that information, you've got that data with you. I think the key things for me that makes it sort of massively transformational is, firstly, we need insight, not just data. It's very difficult when you're rushing around, as I've just demonstrated, how do you navigate yourself if you've got sea of data, numbers, information, even if it's presented in a really clear way, what is it actually telling you? So I think the first thing that I value the most is when the data is used to give insight, and the insight starts a different set of conversations, and the different set of conversations can then lead to an action or a piece of transformation. So I think that's definitely the first thing I would say. The second is the ability to track impact. We're always making decisions. We're always going about doing, things differently. But without proper analytics, it can be very, very difficult to know whether what we're doing is working or not. I think certainly in the area I work is some things sound like they're a really good idea and they've worked somewhere and we plough into them, but we don't always then have the sort of analysis that sits behind. So the insight and the ability to track the impact. I think it's also really important for, like, I'm a career manager, so I've been doing this for 23 years. I can sound really convincing, even when I don't exactly know what I'm talking about. The lovely Adam, who's in my team in front of me here, will stop me and go, yeah, but that's not what the data says, Sarah Jane. And I'm like, oh, okay. But it is really important that we've got that ability to be able to challenge with the evidence. And I think that every body in a position like mine, and I'm sure everybody else on the panel, needs somebody on their shoulder that's got the access, that can unlock some of that analytics, that can actually bring some of those judgments that you're making back. And then my fourth one's a bit more flippant, sorry, but sometimes we just need it to be proved right, which is another thing I'm always saying to Adam is, Adam, I'm now going to give you an anecdote and you will find me some data to demonstrate that this anecdote is indeed quite correct. And sometimes it is, but it really strengthens when you can bring those two things together. I think just to finish off, in return, analysts have to be included. Analytical work is not something that you can just commission in an email and say, you know, can you have a look at why this is happening or that's happening? Analysts need to be in the heart of whatever the team is, executive team, whatever that might be, so they understand, or you all understand the context of the work, and then can then start to shape what the questions are, and therefore the sort, you know, what we're trying to use the data and what we're trying to analyse for, as opposed to other experiences I've had where essentially analysts are, you know, asked a series of questions that they answer, and then people will go, well, that's not quite what I was looking for, but no one's got any idea because they don't actually know what the hypotheses were in the first place. So, like, just 100% central part of the team, and then you get that sweet spot, I think, of the sort of bringing people in and the reward of having, you know, that insight in the team. So I hope that's not been too repetitive, and that's what I'd prepared, thankfully, yesterday afternoon.
Thank you very much. No, well, so you didn't know this, but then strong themes running throughout what you have all said. We've got a really good long period of time now for questions. Every other session I've been in chairing, I've stood up and said, right, we've got time for one question. We've got about 30 seconds left. So I'd like to take some questions. Maybe I'll take 2 or 3 at a time, and then you can sort of pick how you respond. Can we start up on the top right? Oh, you have a mic coming. Don't worry.
Thank you. I'm Sigala Mitai, and I'm working at Nottingham University Hospitals. I'm an improvement analyst. So my question is, what you're describing, all of you, is what analysts want to do. Okay, I won't speak for everyone. What I want to do. And it's also how we, or I, want to work with decision makers. So if that's what you want to do and that's what we want to do, what are the barriers to it actually happening? So what do you think are the barriers? And also, do you have some ideas on how we could overcome those barriers?
That's really nice, thank you. Who else would like to ask a question? There were some hands. Let's just keep working down. If we could go here and then here.
Hi, good afternoon. I'm Kate Tuma. I'm a director of evaluation, and I wanted to, so I think evaluation is something that historically the NHS has struggled with a lot. Observations from some of the work that myself and my team have done, people don't always want to hear the results of those evaluations if they're not quite what they anticipated. So coming back really, Sarah Jane, to your point about here are things that are a really good idea, and we want to kind of show and prove that they work, or what if they don't work? So just, I really welcome your thoughts and reflections on how the evaluation analytical community can work with decision makers to help kind of learn the lessons even where things haven't gone well.
Okay, that's wonderful, thank you. There was someone just in front, there you go.
Thank you very much. I'm Keiko Tom. I work as Head of Analysis for UEC in the Southeast region. I'm very interested in how you've built a culture of good use of analysis in your teams, and how your your use of data and analysis has changed over your careers. Thank you.
That's lovely. Can we go at those three? So the first one, we all want this, but what are the barriers and how would you overcome them? The second one, how do we get evaluation more prominent within this? And in particular, if the evaluator's coming along bursting bubbles, yeah, you're not always welcome. And then the third one, how do you build culture to make this work, and how have things changed over time? I'll just wait for one of you to blink. There you go. Kieran, you moved.
I'll have a crack. I think, I think the barriers is an interesting one, because I think it's very easy to get sucked into all the must-dos on a daily basis. And I think at the end of the day, there are some must-dos that we've all just got to deliver, because Sarah Jane breathes down our neck and says, you've got to have this information.
In a nice way.
In a nice way, certainly. But no, there's a set of stuff that we just have to do, isn't there? But I think you've got to look beyond that in order to generate the permissiveness to do the really exciting stuff. And I think we can do that if you've got the right culture within the organisation. So take you back to what I said about the stuff we did on inequalities during COVID. Nobody asked us to do it. Nobody forced us to do it. But actually, we just thought it was the right thing to do. So we set in train the partnerships to plan what that looked like. And if anybody's read the BMJ from last week, you'll see the interview that P&I director and myself did with them to say that we planned the second question, which was the evaluation at the outset. So I think too often we don't plan the evaluation. And I go back to what I said about winter planning. We throw lots of stuff at the same problem without evaluating it, so we then don't know what worked. And it doesn't answer the question. So I think evaluation is a fundamental foundation of everything that we should do. And you know, I'm a bit of a nerd and I drive it from the R&D side of things. So I think if you can't publish it, nobody will learn from it, and it won't be of a good scientific integrity. So evaluation is critical. And that then embeds a culture if you start to think in that way. And I've certainly done that with my guys to say, look, at the outset, if we haven't planned evaluation and made it publishable, then ask ourselves the question of whether we're doing the right thing. That's my view.
Yeah, thank you. Yeah, a few thoughts. I think on the barriers, it's really interesting because I'm in the same system as you. And I was talking to some of our analysts yesterday and they were saying, oh, we'd love to work much closer with the hospital analysts or the provider analysts. And, you know, how can we get that conversation going differently? So I think the barrier is just convention, and people are used to working in a particular way in different groups. And our leadership challenge, and be really keen to sort of take that forward, is to how do we form some different communities that work, because that's the whole point of integrated care systems, is that we're joining that up and thinking about not only the data but the relationships across as well. So I think, you know, we really welcome that. I think on the evaluation piece, I do agree. I think it's sort of not quite research, so people can sort of say, oh, it's not research. It hasn't met all the, you know, gold standard sort of methodologies. And also, there is human nature is to pay more attention. Our brains work in a way that we're biased, that we pay more attention to things we agree with and tend to disregard things we don't agree with. And so that doesn't give you necessarily the best solutions to things. And that is one of, again, I think that is one of the things that is a leadership challenge within integrated care systems, because we have to come at things with all the relevant sectors, parties around the table with their own perspectives, with genuine curiosity. And evaluations, I think, are a brilliant way of doing that because they're quite quick often and give you really rich insight. And we've had exactly the same conversation about the winter planning and what did really work, what didn't really work, where should we target our resources. So I think absolutely keep going on the evaluation. It's really valuable. What's changed over the life of the career? I think we've got access to much more analysts and analysis than we had, possibly too much, and it's about how you sift, you know, how you get meaning out of it, as Sarah Jane said. But I think it is more accessible, and it's also more, some of the software now, it's much more, you can actually interpret it and look at trends much more easily than previously. So again, I think it's about joining up the conversations and making sure we really value the insights in the way that we make decisions. Thank you.
Thank you. So, I mean, I work at a system level, and there are certainly, without doubt, there are information governance barriers at the moment around. We seem to get rid of quite loads of those in COVID, actually, but they seem to have come back. But there's a fundamental issue around general practice data at the moment and who owns general practice data, which I think when we're able to smooth that out will be very, very helpful for that improvement, as opposed to being used in a performance field, and so it's the use for which people are able to release their data. I think Ahmad's quite right about you're quite happy for data and evaluation to be there as long as it proves the point that you're right, and if it and it depends on, you know, a lot of it is, you know, when you're being driven at speed, be that by externally or internally by people who believe that they are right, then actually they don't want to hear that they're not right, and that can be quite difficult then to get. So when we're looking at, since Sarah Jane's here, about winter pathways, do we actually know where the constraint is and where we should be investing, or do we continue to invest in where we always have done, or because something works there that it will immediately work somewhere else? So there's kind of the true intellectual curiosity and rigour around some of this that is not always allowed time. In a cultural point of view, I mean, I'm from a medical background. Doctors love data, but only if they're proven to be the best. If you're not proven to be the best, the data is old, the data is wrong, and my favourite, my patients are special. So you know, it's fine as long as you're the top, and then you don't question any of those because the data is obviously right. But it's when you're not, and it's how and there's something about data being good enough as well, because again, doctors are used to things for research, particularly with data, where data is very correct. You know, it is correct. Well, except when all the fraud is exposed. But generally, but that you then have to move to be able to cope with data that is good enough to answer the questions that you are getting without being perfect. Because again, when you're proven not to be the best, what you do is you go down, to a single data point. You go, well, that one's wrong. I told you it was all rubbish. And it's us getting to the point of understanding what good enough is in that context.
It's wonderful. I didn't realise analysts were in competition with human nature. My bet is with human nature, I think, at the moment.
Yeah.
Sarah Jane, have you got...
Yeah, just briefly, I think, like, why isn't everybody... my sense is, I may be wrong, but I think often analytical teams are sometimes lumped in with digital or something else, and therefore the sort of... I've written down how many places have got chief analysts, or I don't know what the answer to that question is, but I'm guessing often the sort of head of informatics or whatever the title is buried somewhere down in the organisation and then represented in the executive or the board by somebody who's probably speaking on behalf of something else a bit more. So that's my impression of what maybe one of the challenges might be there. I also think where we really need to get the alignment is with some of the ops stuff. So we've got people kind of really working in real time on what things are saying, and can that change a decision that we make next week, next month, rather than it being like a performance-driven accounting for what happened thing. And that's quite a cultural shift, isn't it? So I think that's probably where it's working well. Certainly in like my team, that's where I think it works really well. Like having the embedded analytics in the team is, rather than it being over there somewhere else, feels really critical. I think in terms of like the challenge and stuff, if something's not great and we're evaluating it and saying that doesn't really work, it's still really good to give the lessons of what it does show and do, because no one wants to think that they've wasted 2 years on something that's awful. And there's always something in the data that you can take from it, even when the thing itself hasn't worked. So I think just trying to take other lessons or frame other questions from something is helpful. I do think the culture's changed. I do think people use data and information more. There's more ability to go online and sort of manipulate your data for yourself and so on. But the onus is really on the team leaders, whoever they might be, to keep asking the questions about what the data or the whatever is really telling you, because you won't change a culture if people are prepared to change a service off what someone said to them in the corridor about X always being late for theatre, whatever that might be. We're not going to bring this in unless we're saying yes, but what does the data, So the leadership of this has to come from the non-analysts being really sort of interested and inquisitive about what the data is leading us towards.
That's wonderful, thank you. We'll take a few more questions. Anyone else got a question? Because you were so polite in the decision-making session I did, you get first dibs at this. This is payback.
I knew there would be payback quite quickly.
There you go.
So this is a horrible question, but it's sort of based on the first one that we had as well. So, sorry, Mutar Ali, Blood and Transplant, Head of Data Management. Through my experience and also kind of reflected from what you were saying, it tends to be personalities that drive good data culture. And I suppose my question is, how do we get from a place where it's not personalities leading to the data culture, because that's not reproducible? How do we get to a place where the system and the structure kind of leads us to good data practices, good data culture?
That's wonderful. Any other questions? Yeah, oh, no, I can't refuse my boss a question, can I? Peter and then Gordon.
Yeah, thanks. We currently don't have a professional structure for analysis. So I was just interested in any reflections you have as leaders about how you make a judgment on the quality of analysis that's presented to you, given that things like attribution of causality are really quite complex, and there are plenty of examples out there of analysis that reaches highly questionable conclusions.
You know there are bear traps in a Peter question. And Gordon, you had your hand up, yeah? You did, yeah. And just the final one there. And then, yeah, that should take us to time. Go on, you can meet in the middle.
It better be worth it now, eh? Gordon Stovin, I'm head of colouring in at Worcestershire Acute. It makes me, from what your feedback, you want creative, highly technical analysts with operational and clinical nous, and you want them capable of influencing the organisation at every single level. So I'm looking at 4 leaders, and I'm asking how you're going to raise our profile amongst not just your own organisations, but amongst your contemporaries' organisations as well, because I see a lot of people around here who have been fighting this sort of, it feels like a little bit of a war of attrition for quite some time, trying to raise their profile, trying to raise their place. I think Hacker's a brilliant example of the need for this. But we also need some sort of top-down support. We need a hand up, not just a push-up as well.
There we go. Oh, you got a challenging second round of questions there. That's nice. So we have got about 6 minutes left. So you can just filibuster to the end and avoid the questions if you like. Go at it in any order you want. I just saw you blink, Amanda. You definitely. Yeah, there you go.
Yeah, I agree with you about the personalities thing, and I think we have to get data and analysis part of our problem-solving teams and decisions as well. And it is up to us to sort of champion the role and invite in to conversations so that analysts get they get more exposure to the conversations around the decisions and how the data plays into that, because a lot of decisions are not only based on the data, they're based on what's feasible, what's political, what's affordable. That they are often it's trade-offs, and so it might not look like the best decision from a purely objective analytical lens sometimes. So I think the more analysts are part of those conversations, I do think that we should have a sort of a proper sort of career structure and network of practice and things like that, and that's partly why this is so good. The quality of the analysis, how would I assess that? I think it's partly how it's described, and I always think when analysts say it's because of this, you can't conclude that from it because that's a gap, or this could be that, or it could be that. I always really value that, and how comprehensive. But I think then we would always have to put that with other tacit knowledge. So is there a big factor that hasn't been taken into account because it's not in the data set or other things? So I think it is we would then piece that bit of information together with other things. But I do think, as we did in COVID, where we had the data front and centre, it was on the telly with all the, forecasts and modelling, we need to make sure that is business as usual and how we operate rather than patchy and just in a crisis.
That's great. Maybe Clara?
Yeah, I'll kind of try and tie them all together a little bit because of time. I think COVID, the corona bonus, as one of my friends called COVID, was that actually there was lots more data that came through and we used. I mean, certainly I was very involved in the vaccination programme, and that had loads and loads of great data that came through. So we started to use it much better and we started to share it much better. The other thing that happened during COVID is that there were a lot of burning platforms that we just got on with things. But I think we then have to go back to system and process a little bit more, that we've kind of lost some of the true discipline of working through decision making associated with data and then coming through options. And as Amanda says, there are many trade-offs within these, but at least you have made a decision associated with data as opposed to going with a gut feeling that actually we've been quite used to over the last few years. So I think it's about sponsorship for us around that process of proper decision making and bringing the analysts into that is something that's important as leaders.
Yeah, that's wonderful. And then maybe Kieran and Sarah Jane.
I'll try to be really quick. How can the system help? I've been guilty of sending out templates when I worked at NHSE. But looking back, I think I wish I'd asked the question and jointly developed a template so we then collectively get the right data. So it would probably help in joint planning. The quality of the analysis, Peter, I think, has to be able to be critically appraised and stand the rigour of good quality data assessment, because if you don't, you risk making the wrong decision on the wrong data, and too often we've done that in healthcare. And that leads me on to how you raise your profile. Respect is earned and not granted. When you publish high quality stuff, as you get recognised, and I think that's the way to raise profile and to become more professionalised going forwards.
I think my point's very similar, thank you. The first one about how can we design it in, I mean, we did try with this year's winter planning, this year's system plan process, maybe not completely successfully, to bring an element of that in by asking people to do proper capacity and demand plans, rather than just sort of, filling in numbers on a spreadsheet. But the more that we can do to the way we frame questions and the way we, all the interactions that we have got some element of being data driven, I think that helps to embed the culture. In all honesty, Peter, I don't have any methodology by which I QA things. I just assume that if Adam's done it, it must be okay, and I'm sure it is. It's a great question. How do we QA? I've written it down as a note to self. It's a good challenge. I think often we just don't. It just sounds clever and we don't completely understand it, but we just need to get on with it, so we just accept it. So I think it's a great challenge. I don't know the answer. I think we don't, there's some great examples here of telling stories, but certainly going into a national role, my eyes have been open to the impact that the analysts have on the way that the whole of healthcare, the resources, the case that we're able to make for how much money the NHS and to an extent social care needs, and what we'll actually be able to collectively deliver in terms of outcomes and everything else, is underpinned by an analytical, starting point of what is possible. And a lot of what analysts are doing are actually driving, as I sit here, what 24, 25 is going to look like for everybody working in the NHS and everybody that uses it. But I wouldn't have known that, and I don't think that story is told particularly well. So I do think telling some of the stories about the absolute impact that this has is important, and probably in other professional areas we've got a bit more storytelling about impact. The finance community are an example, aren't they, of what they've tried to do there with some of their networks, or proud to be ops or something. I don't know if we need something that's a bit proud to be analyst, doesn't sound quite right, sorry, but I'm sure there's something more profound than that. But having some sort of movement, to me, sounds like something that maybe an ask of this group of some description sounds like it could be helpful.
That's wonderful. Certainly a few years ago, we tried to kickstart something we call the Analyst Revolution.
Right.
We were trying to incite insurrection. But you see, we're all too polite. No one was storming about.
You might not got the data to back up your plans.
Yeah, exactly. We were too scared. No, it was the wrong question. Look, let me just invite everyone to say thank you to the panel. That's been a wonderful discussion.